This talk is going to be on the rehabilitation of a rotator cuff injury, post surgical management, and current updates.
So understand the timeline in the rehab. It is going to be a 1 year program, and only in case of traumatic rotator cuff, you can expect for full functional and back around 6 months time. And it is always going to be ups and downs, and educate the patient primarily that the functional will gradually only improve over a period of time, and the pain is going to gradually only go down, and there's not going to be any disappearance of pain. So to understand the why the delay or how the changes happen, it is because of the healing time that is required by the structure. So we are looking at something at the 6 months time when there is going to be complete healing. So in the surgical note, look for what kind of surgery is done and what is the finding in the intra-op, and the MRI finding could be different. And in the discharge summary, see for that so that you will know how you are going to do. So you can always have a associated problem of tenotomy or tenodesis also. So the factors affecting will be the type of tear, size of tear, the quality of the tissue, whether there's fatty infiltration, and whether there's a single row or double row. So the initial plan is to protect the repair for healing, only then to regain full. Sometimes in the elder patients, we might not be able to have full range of motion. Then retraining is getting back the muscle functioning and then progress to strengthening, proprioception and movement automation should come, and then if necessary into sport specific. So these are the components what you can use in your the rehab. The muscle recruitment, you can do it with isometrics, you can do with multi angle, multi position, you can use electrical stimulation, you can use taping. Then to have a pain-free range of motion, you can use ice in the acute phase. In the chronic phase, that is after 3 months or 4 months time when the patient wants, you can use heating modality, but not in the initial phase. You can use TENS, you can use Faraday current. Then functional integration with the glenohumeral, you can use the closed kinematic, open kinematic. Then movements with the electrical stimulation itself. Then you can use taping, both kinesiology and rigid taping for various purposes. And then progress to shoulder strengthening with bands, weights. So the checklist should be to have routine activation and self-activation throughout the period of the rehab so that the patient themselves know that the proper activation is happening. So this is modified deltoid isometrics. This is I'm doing for this patient because he was struggling with his abduction to have the deltoid recruited. And this is the structure what you can pick it up when you start the active range of motion. So the open and mini open or the all arthroscopic rotator cuff. So you can have to know the factors that will be affecting the rehab program is if the quality of the tissues are good and the integrity is good, then you can be little aggressive. If not, it has to be poor. And one of the important thing is if you have a supraspinatus infraspinatus repair, avoid passive internal rotation and then start the external rotator strengthening late. And if it is going to be a subscap repair, start the internal rotator strengthening little later. So again, the single row and double row, depending upon them, will have the vulnerability of giving away. So the other important is the immobilization period. So the longer the immobilization period, you can end up having a stiff shoulder, and the earlier mobilization, you can develop a tear without getting proper healing. So sometimes in our patients, what we do is if there's a very massive cuff tear and the patient compliances is going to be poor, we will be rather having a stiff shoulder and then working on rather than allowing them the early mobilization and having a re-tear. So consensus is about 4 to 6 weeks. And you can start your active range of motion at 2 months to 2.5 months, depending upon a very massive cuff. This could be the earlier exercises, isometrics, when they are on an arm's length. And then start with active assisted with a cane wall exercises. and then progress to active range of motion at the 2 months time, and start strengthening at 2.5 months to 3 months. So you can see this pattern of movement, how this guy is doing, and he's using the trunk as a compensating mechanism, and there is no differentiation of the glenohumeral movement coming. It is working as single unit over here. So this gentleman is about 5 months post-op, able to do only till shoulder level. So usually the cuff, massive cuff, we tell them the first target is to achieve only 90 degree. So he's struggling to go above 90 degrees. So the plan is to progress him to above 90 degree. So I'm using gravity eliminated methods. So these are some of the gravity eliminated methods. And this is for abduction, where you can eliminate going from 90 degree and above without compensating. And I'm putting him on a wall so that he get a good scapula stabilization. So that will allow the glenohumeral to disengage and function. This is short lever to long lever. Getting the biceps worked upon. Now in lying, again, you can get a good scapula stabilization in supine. Utilize that mechanism to get the flexion. Excuse me. And then in the lying mechanism, we will also use a wedge for about 40 degree wedge. There you go. That's a wedge. And then get the flexion coming up. And then progress this wedge to about 60 degree. And then progress to get the range of motion. So the scapula functioning is reported well in how they get this problem, and we call this into a shrug sign. So this is basically not having proper control and recruitment or participation of the scapula muscles in the glenohumeral. So this is one of the primary problem you can face with your rotator cuff patients. So this is basically the vectors of the lower trapezius and the latissimus dorsi not engaging and able to control. So the strength recovery will be there for these patients at 6 months' time in terms of the traumatic or the good quality cuff, and the other patients maximum 1 year they will be able to get. So the re-tear chances are really higher in terms of cuff repair. So we have to balance them. So this is a patient who had a traumatic rotator cuff, a police gentleman, and you can see the range is much better and without much compensation. And this gentleman is 3 months old, cuff repair, where he had a polio, and we wanted him to start mobilize as early as possible. So we started him putting on a walking with his own crutches at the 3rd month time itself, even before starting the strengthening, because we know that he does not need any overhead activities. He just needs to walk with his crutch straight away. So at 3 months' time, we were able to get him back into walking. So take home message, educate the patient before itself how the rehab journey is going to be. Always discuss with the surgeon on the tissue quality and the kind of uh, repair they have done, single bundle, double bundle, and how the stable it is. Observe the pain intensity initially, and then concentrate on the muscle activation at the early rehab phase, maybe even at up to 2 months, and then gradually improve the range of motion. Control the accessory movements, the shrug shine, and the compensatory mechanisms. Ask the patient to properly follow up so that you can give them full functional recovery. Thank you.